readmittance to the hospital. After hearing from our presenters, I will open the floor to you all to ask questions and share your experiences with discharge readiness. With your participation, this session will provide a great opportunity to exchange ideas and best practices. It is my pleasure to begin this afternoon's presentation by introducing our presenters. Paula Stokes leads the Research and Design Division of the U.S. Department of Veterans Affairs Patient Experience Program. This program has worked to define, design, and is currently deploying the VA Patient Experience Framework and toolkits across Veterans Healthcare Administration to improve experiences for veterans, families, and caregivers encountering services. Prior to joining the Veteran Experience Office in March 2016, Ms. Stokes served as the Associate Director of the Tuscaloosa VA Medical Center since 2011. Additionally, she served as an administrative assistant to the Associate Director, Human Resource Specialist, Employee and Labor Relations, and as a certified recreation therapist in the VA. Ms. Stokes earned a Master's of Science degree and a Juris Doctor degree, and she maintains licensure with the Alabama State Bar. Lourdes Colon is a registered nurse with over 30 years of experience. She obtained her bachelor's degree from the Catholic University of Puerto Rico when she worked in the ICU for 6 years, and then started her VA career in the VA North Texas Medical Center, where she obtained a critical care certification. She obtained a Master's of Science degree in Health Administration and Health Informatics at Trident University, and she currently works at the West Palm VA Medical Center in Patient Care Nursing Service as a nurse informaticist and as the Automated Data Processing Application Coordinator. She is the co-chair of the VISN 8 IPC Steering Committee and also the chair of the VISN 8 Nursing Informatics Committee. Ms. Colon is on her 24th year of federal service. Before we get started, I need to share a disclosure statement with you related to nursing education credits that are being offered for this session. The Maryland Nurses Association is an accredited approver of continuing nursing education by the American Nurses Credentialing Center's Commission on Accreditation. If you wish to receive credit for attending this activity, you must complete the session survey found on your conference mobile app. In the survey, it is important that you check the box indicating that you would like to receive credit and enter your full name and email address in the space provided. Your certificate will be sent to that address. In compliance with the continuing education activity credit conflict of interest disclosure requirements, we'd like to announce that the presenters of this session have no commercial association that would create a conflict of interest. Paula Stokes will kick off our session today. Welcome, Paula.
Thank you. So I'd like to have a conversation. Do we have the mic ready? Okay. I'd like to have a conversation more than presentation. And so we're going to kind of tag team talking about the inpatient research from the Veteran Experience Office and then how VISN 8 is using that with the GetWell network. But interject any time with us because we want to make sure that we have a conversation. One of the things that even Ms. Colon has shared is many people know the Veteran Experience Office but may not know all the details around some of the work we're doing. And so we're hoping to share that today. But please let us know. We want to make sure that we answer your questions, make sure you understand how you can integrate things, how much flexibility you have and what we're doing and things like that. So first I want to start with what our agenda is. We're going to talk about the Veteran Experience Office a little bit and the research project around inpatient experiences, specifically the discharge experiences for our veterans and their families, and then our research findings, which has led us to 3 inpatient tools that I'm hoping you all are familiar with, and one is the Discharge Checklist, which VISN 8 has been able to embed in the GetWell network that we want to share with you today. And then we're going to have VISN 8 to talk about their overview and how they use the Discharge Pathway design and their next steps. So trying to integrate what you have across VA, what we're doing with inpatient and discharge experiences, and how you can use it with GetWell network if you already have the system. So the first thing I want to know from you all, how many in here are familiar with the Veteran Experience Office? I've heard many conversations. Okay, awesome, good. So first thing I want you to know is our ultimate goal is to improve patient experience, but we know we also have to focus on our employee experiences. And so when we look at it, if you see this slide, you'll see that we want to make sure that our patients, our veterans, can get the care or services they need. It's easy to get it, and they feel valued. But when we think about that, we also have to think about our employees. Do they have the tools and training they need to do so? Do they feel empowered to deliver this experience we want them to? And do they have the tools and the systems to do what we need them to do? And ultimately, if we work all that together, we can improve the veteran experience and our employee experience. And ultimately, we become the choice of healthcare for all of our veterans. So what I wanted to start with is our inpatient research, as I mentioned earlier. And I know it's after lunch, so I'm going to try to engage you a little bit and be in your face a little bit so that you can stay awake. The first thing I want to talk about is our inpatient research. I don't know if you're familiar with it, but our inpatient research was started by our SHEP scores. And I know you're probably familiar with the SHEP survey. SHEP survey shared with VA, basically through the numbers, that we had some room for improvement. When we looked at it, we knew that we needed to study more of inpatient experiences. But how many of you all get SHEP survey results and only thing your leadership tells you is you need to improve them? I mean, do you get that all the time? And you're thinking, how? Why? I mean, I'm doing everything that I can do. A lot of times when I go on the units and working in the medical center myself, and I talk to staff and they say, what more can I do? What more can I say? I'm communicating. I mean, come on, what else to do? So our office ventures out on that and say, okay, how do we better understand what those numbers are saying to us? What's the quantitative and qualitative study combined together, and what can it tell us that we need to do to improve? And so we go out and we do interviews through human-centered design to better understand those numbers. So yes, you're saying we're doing poorly in patient preferences, but what does that mean? Patients tell us more. What are you wanting from us? What are your expectations? And so that's what we seek out. And so looking at the SHEP survey, we knew we needed to go out and focus on patient preferences, needs, and communication. We need to stop telling our staff to communicate more, but find out what that intentional communication can be. And so we studied that, and we realized that even if we do those things, we could also improve readmissions, ER visits, and the healthcare outcomes. And so we went out to understand those needs of the veterans and their families and their caregivers. Oh, what? Okay, so this is actually the human-centered design research that we follow. Are you all familiar with human-centered design, and do you use that? If not, let me know, and I can help you even after the class to understand how to best use this. But we go through this process to better understand what the numbers are saying. We get out to your medical centers, and many of you in this room, we've probably been to your medical centers, and we're going through our pre-discovery and discovery, understanding more, taking those numbers to the medical center and saying, we want to learn more. And when we do our discovery, we then use that to say, now, how can we design something to respond to it? How many of you all are familiar with V-Signals, Veteran Signal Survey? Thank you. I'm glad you are. So how many of you all knew that the Veteran Signal Survey came from this type of study? Very few. So even Ms. Cologne shared with me that. She said, you know, we don't know where you get these questions from. All we know is we have questions. So the questions from any V-Signals or Veteran Signal survey that you're seeing comes from human-centered design research. We've studied enough to say we have numbers, we need to better understand it. How do we design something to respond to it? But how do we continue to measure it to see if we're doing something that really works? So V-Signals is developed from human-centered design research. One of the ways we do it is when we're into the medical centers, and this will show you an idea of how we gain the insights around inpatient and discharge specific experiences. We went to medical centers, and I have them listed there. We went to medical centers, we visited so many, we interviewed so many veterans, and we interviewed employees. Because not only did we want to understand what the veterans expected, but what are the employees doing, and what are they seeing, and how does this fit together? And so we use all that, we gather those insights, and then we say, okay, we've learned so much more beyond just the numbers of what the SHEP survey tells us. What do we do to respond to that, and how do we continue to measure that? We build the V-Signal survey. So one of the things that we learned from the discharge research and generally speaking inpatient research were the moments that matter. How many in this room are familiar with moments that matter, the terminology moments that matter? I'm ashamed that now that one, come on, thank you. So one of the things that we emphasize in our research is once you study and understand, you will learn so much you need to improve upon, but you have to have like a summary of what am I going after. We can't chase everything. We know in VA we've tried to fix the world and it's never happened. We just continue to run after things. So what we decided to do was focus on what we reference as the moments that matter. When we study what the veterans are saying and what our employees are saying and what the caregivers are expecting, we can summarize all that research so that the field can use it, but tell them where to focus their energy. Focus your energy on the moments that matter. And so when we looked at the discharge experience, we knew that the SHEP survey, we have specific questions. We know we're asking these questions. We know how we're doing on those questions. But what does that really mean to our patients? We were able to talk to them and come up with the moments that matter. So we have 3 moments that matter for the discharge experience. 1 is ready for discharge. In the research, this one really surprised me, because the veterans say, I hear the word discharge, and I assumed I was about to leave. I remember back some years ago, only thing I heard was, we're not telling the veteran when they need to be discharged. So now, guess what? We're telling them, and too many people are telling them, and we don't have any intentional conversation around it. So now that's a pain point for the veteran. The nurse talks about discharge. Everybody comes in the room, talks about discharge. And so it gets me anxious. I'm thinking, okay, you're going to get ready to discharge me this morning. You started talking about it at 8 o'clock this morning. It's 8 o'clock tonight. What's going on? So now we've overused the word discharge. When we're trying to respond to the SHEP survey, we start using that word, but we're not intentionally using it. We've caused another pain point. So the patients say, be careful what you do with that word. Make sure it's intentional when you use it. Have some time frames around it when you start using it so that you don't create anxiety around me and those expectations that you're not going to follow. The next one was review the discharge instructions. I'm overwhelmed with all the information. How am I possibly going to remember all this at home? Now, we know in VA we have discharge instructions. And then do we think about the fact that we've been talking about discharge since 8 o'clock this morning? We come in with the discharge instructions at 8 o'clock tonight. I'm so anxious. I don't hear anything you're saying because you've made me so mad. I don't hear anything you're saying at 8 o'clock tonight. So why don't we think about not just what information, but when we give the information and how we give the information. These are the moments that matter. So if I want to turn SHEP around, follow these moments that matter, because this is what really turns the experience. The last one for discharge was travel home. They all kind of interrelate. I need to let my family know when to pick me up. I wish the doctor could give me a day and time. All that's around discharge. We don't even realize that all the focus around the experience of discharge is around timeliness and talking to me, being intentional. With the hospitalization experience, there were many more moments that matter, and I won't use our time, but I will share these with you all. But look at it from the standpoint of, this is what the patient says that matters to me. If you really want to improve your SHEP scores, understand what matters to me. Because in the SHEP questions, you're asking me specific questions. I don't have room to really tell you much other than yes or no or rate you. But now I can tell you what matters to me. Do this, and you'll improve my experience. So I want you to walk away with knowing the moments that matter, if nothing else. And for all the research we do, there's always a journey map that we reference. And at the bottom of the journey maps are the moments that matter. So if you look at the 2 small print here, hospitalization experience and discharge experience, those are 2 journey maps. They're very small, but if you want them, I can make sure we get them to you. But you see the color-coded boxes at the bottom? Those are the moments that matter. We really want you to know those moments that matter, because not only do you get to utilize the tools I have for you or the tools the GetWell Network has for you, but you can build future tools by your moments that matter. So when we're talking and we're saying, what else can I do? Let me use the journey maps. Someone's gone out and studied this for me. Why don't I use this tool? And so think about using the journey maps, and it will give you the journey of the patient from admission through discharge and what the patients, the family members, and the employees said. And it will help you kind of narrow down. Instead of chasing numbers, you chase conversations and you understand. So one of the things here to connect what we want to share with you today is understanding what our office produces for you. In the arena of the hospitalization and discharge experience, these are tools that we have available for you. When we do our research, we're not doing it in vain. We're not doing it just because we want to do it, but we want to create things for you to use in the field. So if you look over to my right, your left, you see defining and measuring inpatient experience. That's a storybook that we created to summarize all the research and all the insights we gain. So when you're working with GetWell Network, when you're working with your teams, you can use this storybook to say, let me see what the patients are really saying around question number 23 for the SHEP survey. Because everything we did, we base it around those questions. And then you also have the journey maps that you can use. But as I mentioned earlier, the inpatient tools that you're going to see coming soon, most of you all will see them at least by May this year, are the Discharge Checklist. The Prepare for Care is a caregiver booklet to help the caregiver be more engaged in the inpatient and preparing for discharge, and the Journey to Discharge booklet. These are things that, yes, they are old-fashioned paper copy, but these are things that the patients design with us from those insights. In our research, when we go out, we don't just ask questions of the patients. We go back to the patients and say, okay, you've told me this. Now let me see, how do I respond to this? Let me build something based on what you've shared, and you help me continue to build it until I get it right. So these are tools that patients have helped us. Yes?
And this can be put on GetWell.
Yes, that's what we're going to show you today. So at least the discharge checklist is already done, and Ms. Colon is going to share with you all how Vision 8 has done it. Your journey booklet, there are pieces in there that you can engage that in that discharge pathway. Some of it's probably already in there. And one thing we wanted to mention in this particular forum is there's no need to duplicate and have multiple forums put in front of your patients. If there's a way to interact it with the GetWell network, we want to do it. Because you're now in the technology world with GetWell network. Some sites are not there yet, so we started here to encompass all VAs, because what we do, we have to make sure that it will fit in any and every VA. But if you have GetWell network, she's going to share with you more of how they've done. And I have to apologize, I forgot to tell you all in the beginning about my voice being cracky, because something's going on. But what we haven't done, we can continue to build. Know that we have flexibilities in these.
That's the checklist from the toolkit. Mm-hmm.
Yes. Yes. Mm-hmm. The discharge checklist was something, it was a tool that was originally designed by the patients to put in front of the patient for transparency. When we started building this out in the facilities, the staff said, wait, you forgot us. We don't know enough about their discharge, so it needs to be transparency to both. And so that tool was rebuilt around the patient and staff transparency. And what we did was we gathered enough information around that checklist to say, here's a window of time for your discharge, and here's everything else that has to happen to make sure we're meeting that window of time. We know discharge needs to be flexible because it can change, but you can watch and see how much are we still pending. So now the patient isn't anxious. I know that checklist looks pretty empty. So even though you told me I'm going home at 8 o'clock and it's 6 o'clock, I'm probably not going. So you've created that transparency where we're all on the same page and we know that other things are pending. And so the patients really like that, because now they realize discharge isn't just a matter of you turning a switch on and off. Now they see everything else involved in that discharge. So I'm going to stop there because I don't want to take all of your time. But one last thing as we integrate and move into Ms. Colon speaking is to share with you this discharge preparedness checklist that's inside that journey booklet that's already been embedded in the GetWell network to help our patients prepare for discharge. We're trying to reduce the expanded time that we discharge a patient because we've missed something with the patient. She's going to share a little bit more with you on that. I just wanted to quickly summarize the measuring of the improvements. When you have GetWell network, you have multiple sources to measure that voice of the veteran. Please keep in mind they do work together. They are not to be isolated from each other or feel like it's just pain, but you use the GetWell network as that realistic, timely feedback. You continue to use Veteran Signals, and do know, if you don't know, that Veteran Signals inpatient tool is being piloted right now, so I say coming soon, and you can actually look in there as of today and see what responses you're getting, and happy to help you at the end of the session figure that out. And then SHEP. SHEP is not going away. No, we can't change it, but use GetWell Network and V-Signals as your indicators, and I'd love to help you more with that. But for the time's sake, I'm going to turn it over to Ms. Colon now.
So good afternoon. So, I'm going to start it with this quote and end it with it. So we're going to end this, I think, the same way. So one of the biggest things, and I want to show you because a lot of people might hear that Vision A, everybody sucks. You hear GetWell Network team, Vision A, Vision A. I think we were one of the first Vision as a whole to start this program from 2012, and I'll go over. And I guess you already know where Vision A is, in the beautiful Sunshine State. We're close to one of the largest system, and we're like 1.5 million that we served in the veterans. We do from Florida, Georgia, Puerto Rico, Virgin Islands, so it's a big national hospital largest. And then one of the biggest things that we do also, we have more than 7 health systems that include the Joint Commissions. We go from cost-effective quality care, okay? We also do a standard care, inpatient, outpatient, and recently most of our facilities are having a domiciliary too, okay? So when we started and visiting, since we started partnering with the GetWell Network since 2012, this came as an action item. It's like, okay, there's an action item. We need to identify who's going to be the main contact or the POC for that facility. We didn't start it with a manager console like most of us have. So our first contract was just only to go ahead and get that action item going. We're going to implement this wonderful, excellent TV that does a lot. My past director even thought that TV was always going to start baking cookies and coming out of there, because we're talking about their patients were going to do meal and they were going to order things and they were going shop. But unfortunately, you know how our VAs are in our security system. So that got to stop to try to get us engaged. So I think one of the biggest, we celebrated since the day we started, almost like 2-3 years, 4 years ago, that we got finalized, that we get together with the national accepted the system for the GetWell Network to merge with our system. And let me tell you, that was a lot of stones from big, and it was like, so we were always frustrated. We were asking. So being as a visit, we all came by and we talked about each facility was going to have, where we're going to put it, and where we're going to put this, but without knowing that what this thing is going to do. The only thing we kind of being a Google, oh, I love it. It's going to have internet. Patients are going to be able. How are we going to do it in the CLC? Again, it's never too late to improve. Now having the patient experience engage more, now we know, okay? So those are the areas, and you can see how many each facility have. The other thing, after the patient experience got involved, so she decided they got, like you said, something that I just learned, just to advise you. I've been with the VA close to my 25 years and just recently about 24. And I explained to her, I said, oh my God, I cannot believe, I wish I could have you from the beginning. We started the GetWell Network. Why? Because I know when we had this, we would have had the whole tools and understanding. Because still we were saying, oh, check data, how many patients got it? Or one patient, and what was the one? The one that was upset, right? That's the only negative you got. And they said, why? I only have one in that. Well, and that one put the data down. Everybody was so upset. So now that I understand, listen, I'm taking this and taking it up there, explaining more. And it's something that I wish our leadership will get it up there. And again, I don't know if that gets into higher leadership, but probably in the local leadership, that manager, to understand why. Because she was like, okay, we got to increase the, I don't know how we're going to do it. Okay, let's call Lourdes. What else we got to do? So those are the things that I'm glad that now I got it. Again, never too late. Dr. LaPuz started with veterans being decided, well, we just did a survey and went over it, and then they decided to go, we wanted to get a pathway to discharge pathway up there and then try to implement it in our facility. So that was in March, decided to improve or perform an improvement. So we want to standardize as a vision. Obvious, we all so unique. No matter what we said, we can try, and that's something that I brought up with Paula. Like right now, we do have the pathway, and we have the same questions, but we could be probably standardized a little bit in our, and engage it with the one that we're already. Because a lot of people over you and in your facility already have a process of discharge process. This is just going to enhance what we already got. And especially for some facility that I have, from one, they don't have a social worker in the ED. I do have that. They got the ability, so we could get that. And that's something we could bring and storm with her, and you guys can bring those questions to her. Then after we got that engaged and got the information that we needed, so let's go, let's try it, okay, since March 19. So after we did that, did the research, obvious, we went over, and those recommendations started standardized. It was an action item again, okay? Because remember, everything has to be an action item. When our lower leadership understand to the higher leadership, okay, this has got it. Because at the beginning, and I think Carl, Melissa, Chris, they always say, I got to get my leadership more engaged. If I get them engaged, everything is going to go right. So your leaderships have to be in the front at the beginning, and they gotta be engaged. They gotta love the way we are so passionate talking about it. Like right now, I got an amazing acute care chief, and she's so passionate just like me and love it, and she loves the technology. Great. Those are the people we have to target. So one of the biggest things, so we standardized, obviously there was a lot of hiccup, everybody was complaining, oh my God, our medication, people were saying, no, we don't like that question, we misleading their patients, but then we kind of realized that, well, let's try it, let's see how we do it. Some facility, this process was excellent, other weren't, because they have all the process that they were not able, and patient was getting, oh, this is the same question you're asking me over and over, okay? So what we do right now in our facility, and I think some of you might have, so it comes a pop-up, again, from the beginning of the admissions, around 6 hours, and then it comes from different areas. Remember, too, the prong can be engaged from the favor areas or through a pop-up, okay? We do have it in the pop-up, and we can save it later, but we're still going to continue asking, okay? So those are people that haven't seen the discharge pathway. Question will come up. Again, this is all the questions. And again, when you read them, some of you might think that those questions are, oh my God, the patients they're not going to know if they're ready to take those medications. Do they understand? But they don't know what medication they're going to go home. But sometimes when you go and talk to the patient, you are having your regular medications, how you might have some new ones that we might have to talk about it. But then we're going to continue. Let's see where's your plan with those. The same thing, understanding the health condition system. Are you paying attention? What exactly are you doing? Getting them to understand what they need. If eventually we don't know if that patient's going to need some case manager to be there, that probably some prostheses or help at home. What exactly that we don't know that yet, and depends on their conditions. But yes, we ask them. They might say, I don't know. Okay, that's fine. But we can relay those questions back again. Okay. After they do all that questions and the pop-up, patient, if they decided not to do, like I said, it come back once in a while, every hour, 2 hours, it comes back again to ask them to get engaged. Sometimes even the social worker might go inside and start the discharge planning with them to try to get it through, okay? There's also video, which is education is the top one, and that's one of we targeting in each facility right now our vision. We're trying to challenge each other to try to make our educations increase. And one of the big ones we got, that's the way we started it. We didn't start it with a pathway. We just started with a discharge video. And now we engage both of them together, okay? When we did this, we started looking like right now where our discharge planning was already in process. Having this, it was helping us to engage or, seamlessly the process. And one of the biggest things was trying to decrease the leave to stay, okay? Decrease the readmissions that we have, and obviously improve SHEP data. And that was one of the biggest things to patients' understanding, because that question, obviously, cannot be changed, and we cannot even met it and say, hey, can you answer this question? But if we go over there and speaking to the patient, can you answer? There's some questions here similar to those questions you're going to receive at home. And if we get them educated on how they're going to receive those, we're going to get it. Patients are going to understand. They're not going to do it just because. But we're always going to have one or two that when they're upset, they're going to write it no matter what. Okay? And this is some rough data that I have right now. Some of the facility that I put here that you see most improvement when we started it, how they increased it. And right now, some of the facility that they didn't improve because they have all the process. Okay? And again, you have heard this. There's nothing to this technology to work with our facility. I know we don't have the technology merged the way we want it. Like right now, we're trying to engage Vocera communication system instead of an email so we could have immediate response. But I know that's going to happen eventually. We're working on it. That's our phase 3 for the vision. And then you have that, people, but you have to educate. Unfortunately, they said it's a very weak action, but education is the biggest one. And I always say when you go up there and speak to that patient, and you always bring that up, and always saying this is similar question you might receive at home, you're going to see some improvement. And again, getting not only the patient, the family, the staff. Staff depends on the area that you're working. Like I said, today I learned about the new CLC experience, and we started at our performance. We haven't done it. I wish I had it from the beginning. Because why? Because right now I'm going to sell it to that veterans or that resident. Hey, I'm going to customize your TV now your way, and this is going to be awesome to show them how good they're going to be able and how they're going to get engaged more, because I'm going to show them their way. So one of the things, obvious, the people, the process, and the technology, everything. Get the GetWell network to enhance whatever we already have, and I think it's going to work. But obvious, I'm hoping with the new Cerna coming in the future, we will get the opportunity to increase our goals and what we want for our veterans. Okay? And any question? And one of the things that I was just explaining to Paula, and she already reinforced it, was that we could sit down now. And one of the things was for probably in our vision, we're going back again. We're going to be meeting with each of those questions that we have priors. We're going to be probably meeting with each of the Vision A that is in charge of those medications, for example, the pharmacist. So we'll make sure that we talk to them, sit down with them, and try to get the group together, come out with questions. Because they say, oh, I don't think our veteran understand those kind of questions. I don't think our patients sometimes are not interpreting. So we want to get them the input. We might going to meet with the physicians, the case manager, to see what we got and then come out with one. Or we could continue with the same pathway and standardize that question in different areas and different VAs. Okay? And hoping with her help. Yes.
So a question for both of you about we have a lot of sometimes pushback when we talk to clinical teams about the timing of the understand the medications I'm required to take along with my refills. Can you just talk about, like, one is how you implemented it in those discussions in terms of timing, and then also if you same with, like, what recommendations do you have from the Veteran Experience Office with the research that you've done for timing? With any of the questions, really.
Okay, for the medication, so one of the things that our pharmacist says, well, we asking this because, again, like I said, patient says, well, I don't know what kind of medication I'm going. So what we did was I explained to them, listen, they got the standard medication, the routine medication. They might come up with other. It's just to ask them to be aware that you might go home with another new medication. Nothing's going to change, obvious. And also be engaged with their medication list, because that's another thing. Having the medication pathway also that the patient can see when they see something new. Oh, this is what she meant. So those are the part that I think, well, that's true, Lord, is we should just bring it up to them and say, yes, it's all your medications, but you might have a new one coming up.
Okay.
And in terms of timing and where did these questions come from, in the Discharge Journey booklet, those questions sit right in the middle. But the Discharge Journey booklet is kind of a pathway that the patient would follow, and it kind of takes them through phases. I wouldn't say day to day because it could be a 2-day admission or 2-day stay. But as the patient is going through it, it reminds them you are now at this point of preparing for discharge. Can you now go to your discharge checklist? And so there's a point in time that we lead them to that checklist. That was studied and designed by the patients. The questions were actually thought of by patients in correlations with what are the number one complaints through the SHEP survey and after discharge that we get. And it was, I didn't know my medications. When you look at the questions here, it's not a matter of just making sure they understand, but also checks and balances. Because how often do you as nursing staff say, I know we went over those medications? And that patient got home, or before they left, they said, no one went over medication. That's what that's for.
Okay.
And so if you look in our Discharge Journey booklet, it says these are our checks and balances. We ask our staff to go back over that before the patient leaves. So it tells the patient, you're now at a point we want you to start thinking about these things. Go and answer these questions. But before you leave, we want to look at your answers. Because if you say no, I'm not going to send you home without saying, do you not remember Ms. Mary going over this? Making sure we have checks and balances. My assumption is you're going to use it there timing-wise, and if not, we can tweak that a little bit more through your system just to make sure that it is that check and balance, because when they say no, my hope is with your system, and I know with our discharge booklet, it's going to trigger the staff. Whether we've done it or not, we may need to do it again, because that's key for us. Is once again, like I mentioned, intentional communication. We communicate, we do everything we're supposed to do, but it's perception. Experience is about perception. You can do everything just right, but if that patient doesn't perceive that you did it, you didn't do it. And so that's where this comes about.
Mm-hmm. So, my background is in geriatrics and palliative care, and there's always the child of the older adult or the spouse of the older adult who's cognitively impaired. or too sick to be able to answer the questions or keep track of their stuff or what have you. So in what ways have you engaged or researched the informant, the person who's the primary caregiver, or could even be a child who's just in town to take care of the person temporarily or what have you?
I'm going to back up to the tools and let you see how these work together. The Prepare for Care booklet. I don't need it. Okay. The Prepare for Care booklet. That booklet correlates with the patient's journey to discharge. If the patient can engage that journey to discharge booklet, then the patient will go through it. Many times the family member may even take that journey booklet and go through it. But even if not, we're catching it through Prepare for Care. We've designed a booklet just to engage that caregiver who may not identify themselves as a caregiver. In our research, we found that when people use the word caregiver, they say, oh, no, I'm not in that program. Well, you are a caregiver and you don't recognize it. Or they'll say, oh, no, I'm just a spouse. No, I'm not a caregiver. Or, no, I'm just here for day at today. You are a caregiver, and we need to help you understand your role. So the Prepare for Care was built off of the Caregiver Support Program to put resources in front of them, but to have that person that's in that veteran's life start thinking about my role and what I need to do even to prepare for discharge. So that booklet has similar questions and ways that they plan and start thinking about preparing for discharge. Whether I'm a neighbor or whatever. One of our veterans had that booklet when we go back and we test these things with our veterans. And so we were testing, I think we were in Dallas, and the patient looked at it and he said, I don't have a caregiver, but I want that booklet because when I go home, my neighbor's going to help me. And this is going to help my neighbor go through the role and put information in front of them. So sometimes they'll use it themselves, sometimes the caregiver will use it later. But it's so important. VA has shied away from caregivers other than those in the Caregiver Support Program because we don't want to get into the conflict of, well, I'm not sure if I can release this information. And so we're now trying to educate ourselves to say, grab and engage that caregiver a little bit more. When you see someone in the room, help them understand they are now in that role. This booklet, in the front page of it, it tells them we're not going to release any information in any abnormal fashion. We're going to follow the same protocols, but we want to help you understand this role and help you be more engaged. And so that's where we're doing it. And those three tools play well together. They're in paper, but like I said, you can design them for GetWell Network, and that's why we're here to kind of build that partnership for those that do have it, because our hope is to get to the technology standpoint with all of this. We wanted to start with something that everyone could use and measure the impact. And if you look at your V-Signals inpatient questions that is being piloted, you're going to see them correlate directly to this. We're testing it, and we're going to watch V-Signals to see if this is working, because if it's not, we're going to change it. And that's the work we do. Even with your outpatient V-Signals, if you look back to our outpatient journey booklets and some of the tools we give you, you'll see those questions are geared to tell us if we're responding properly or not. So we continue to monitor. But we love your feedback and love to keep partnering with wherever you are, because our job is to meet you where you are and help you build and move further. Not to bring you back to paper, but to introduce the concept. And you have flexibilities around this concept to use. But we've designed it with the patients, we've tested it, and we know that there is some substance behind this that will help you improve those experiences. And like I said, you'll see most of our work is based on perception more than anything. Any other questions? Yes. I'm sorry. So, no, it's not. This is Veteran Experience Office products. We had everything on the Pulse page, but in VA we're moving away from the Pulse page. So we're now creating a forum to put all those things back on. But we're starting... They started webinars last month, and we're going to make sure that all sites have access to this through our webinars. We will be doing VISN-specific face-to-face training on these tools starting in March, and then we will have all the tools available also through the Office of Logistics. So just like you get all your other nursing paperwork, we will have that where you can order it that way, or any way that you want to make it electronic through any current system you have, we will work with you on that. But between now and May, all of these things will hit the facilities. We have our PX Symposium. I don't know if you're familiar with it, but it is one of our forums that we will use to push these tools out once again in May. So we say that there will be national implementation of these tools by May. Now, we've been working and piloting with several sites since last year. So some sites have it now. Some people email me and they get them early and they start working on them early because we don't want to just kind of hold them. We want to let you use them now if you want to.
So I think you, Visit A, will be prepared to when your leadership comes and say, oh, we're gonna do, we already ordered it, we already put it in the GetWell network, do something that we could do up there and get it out there to the staff. And I think, again, get everybody informed is the best thing and educated.
I just want to make a comment, speaking specifically to timing with this, Visit 8. We send the message out to the veteran every day, beginning the day of admission, and it goes out every day at 9:59 a.m. And there's a reason for 9:59. That's when their television shows are going off, not coming on. So it's a time that they actually kind of have a break.
Love it. Love it. Awesome.
Don't interrupt my bonanza.
Yes.
And it's still early enough that Price is Right isn't on yet, so, you know.
Yeah.
Hello, Lord, it's Brian from Orlando. Could you talk a little bit about how the questions are vetted for our discharge planning? Because they align really close to what our SHEP questions are, correct?
Yes.
Which questions are you speaking of?
For the discharge pathway.
Are those the ones in the checklist? I have to look to her because I don't have the
On
pathway.
the checklist?
Yeah, on the checklist, right.
Yes,
Okay.
it's the same one. And
Yeah.
then, again, we we put it together as a improvement way to the Visit A, and then all the questions are similar, and we have the same time for each of us. And the questions are the same, but like our facility was better with our discharge envelope and process that we have. Some facility, like I said, have a different process, but what they did, they just enhanced the GetWell network pathway to improve what they got. And some of them, for example, case managers, they're receiving an alert. At least patient doesn't have it right home. He probably think about it because his wife is working that day, stuff like that. So yes.
And to add to that, with now that I know which questions you're speaking of, those questions, you're right, they correlate very closely to SHEP, but they cannot duplicate SHEP. And the SHEP team actually helped us design those questions along with our patients to say, what are the greatest pain points around certain factors that we can include in questions that wouldn't conflict with SHEP through CMS.
Yeah, we cannot copy the SHEP.
Correct. And the reason I asked that, just so for our newer folks that are in the room, you know, when you go back and talk about this, the discharge pathway especially, it's important to communicate to your leadership that you will be in line with whatever CMS rules, and you're not going to break any rules with this. It's already been vetted.
If you're using the GetWell network actually got the question. Dr. Lapousse, the Vision director for them, for Vision 8, was at the PX Symposium last year. And I introduced these tools, and he came up and said, I want these in GetWell network. And so they basically used the questions. If you're using the exact questions that we've given, they've been vetted. You're good to go. Now, if you decide to tweak them a little bit, I would say talk to myself or the SHEP team before you go out and design some new ones. As Lourdes had mentioned, you know, do you have any flexibility in changing that? My answer is yes, but we want to be very careful, like you're saying, when we change it. But do know that those were designed with the SHEP team to make sure that we didn't have any conflict. Mm-hmm. Yes. Oh,
Do you want to talk a little bit about how you deal with the discharge in the CLC? Since we did talk about the CLC and for short-term rehab stays and not automating it at all for folks who might be deploying.
Yeah, we're not. Yeah, we don't.
You're not doing it?
No.
But you have the ability to order it from CPRS.
We can.
So if you wanted to do discharge planning for patients on long-term.
Now we probably will look into the new platform for CLC and see what we can do for those.
Yeah. So I just wanted to make sure that y'all were aware.
Thank you. I'm Erica. I'm here in the DCVA. I have a query about the books. I hear we're trying to move towards everything being electronic sourced, but will the books go away permanently?
No. The way we do things in the Veteran Experience Office is we put things out and we let facilities use based on where they are. We may have some facilities that say, based on my culture and based on my budget, this is where I'm going to stay for now. And there will be others that say, I have GetWell Network and there's no need for me to go back to paper. So we introduce the concept, but we're not going to just snatch it away. You know, if there's ever a time where we all can just fully transition to technology, well, so be it, but I don't see that coming anytime soon. But even if you see, like, when you look at these, you see the badge there? How many of you all are familiar with the Choose VA badge? That's a new design of the Choose VA badge that I didn't really want to touch on here, but it shows you how we continue to update things based on facility feedback, and we give the facilities options as we improve upon solutions. We say, here's an improve upon solution, but by no means are we saying you must stop what you're doing, waste all the resources you've spent, and move forward. We say, let's meet you where you are, what works best for you. We want to tell you about these tools and help you make them work in your culture for your patients. Does that answer?
Yes. My second question is regarding health literacy. I noticed in one of the questions there was a word that I'm sure a veteran would have got stuck on, who's at a grade 4, grade 5 level, which is what we're supposed to be writing to, although the rest of the government thinks that everybody should be written at a grade 8 level. So that's one of the big jobs I have sitting in the VA, rewording and getting copyright provisions and fixing things so that we have a broader health literacy general sense going out instead of these subsequent. A fourth grader's not going to tell you what subsequent means.
Yes, you're so right. And that's, I think, one of the things Lourdes just mentioned. Can I change the questions? Because when I look at it now, I say maybe they won't be able to read it. We did send it through the, and I forgot the person's name, but through the Health Education Literacy Review, and we were told it was okay. But people like yourselves catch that, and we make those changes. So welcome to work with you and let you do a second look at it, because we just want to get the same message across. If you can get the message easier and you capture more, that's what we want to do, and that's why we want to be very flexible. And that's one of the reasons we pilot the tools. So these tools have been piloted for 8 months now in facilities where patients are using them. And I go in myself and get feedback. And right now I look at V-signals for every pilot site and see how we're doing with this. And so we haven't had patient feedback, but like you say, maybe it's just not the right patient, or maybe someone's not comfortable enough to say it. But if we can look at it again, please, we welcome that.
Yeah, because what I'm finding in my experience at the VA is that everyone's very 508 compliant, happy to say those words, but they completely disregard ADA compliance once you hit print.
You're so right.
And I spend all of my time just about, except when I'm visiting places like this, teaching people there's an ADA compliance that we have to adhere to.
Yeah.
And I would love to see things that are coming out of GetWell Network, whether on, electronically or things that we as a VA are going to keep in print, are going to meet that need.
Yeah, sure. I can definitely send you the tools and let you look at them. And then from a GetWell Network standpoint, the pieces that they're using, we would feed that back to them.
Yep.
Awesome.
Any other question? And again, it's never too late to improve.
And hang in there. Don't get discouraged over SHEP. Thank you.
Thank you.